Welcome to the first NIMH Grief Sensitive Virtual Institute. I'm Heather Gotham, Director of the Mental Health Technology Transfer Center Network Coordinating Office. Thank you for joining us today for the first of two Grief Sensitivity Virtual Learning Institutes hosted by our network. We are incredibly honored, grateful, and pleased to be gathering all of you here. We have over 2,500 people registered from across the country. I'm going to offer a brief orientation to our two-day institute, and then we'll hear from Dr. Shear, who will provide guidance and grounding to help us understand grief in this moment and how we can build and nurture our grief sensitivity skills for ourselves, our loved ones, our colleagues, and those we serve. A quick disclaimer, this presentation was prepared for the NIMH network under a cooperative agreement from SAMHSA. The opinions expressed in the presentation are the views of our speakers and do not reflect the official position of the Department of Health and Human Services or SAMHSA. A little intro on the NIMH network. Our network focuses on technology transfer, which really means the adoption and implementation of evidence-based practices for mental health across the US and territories. We develop and disseminate resources, provide free local and regional training and technical assistance for the mental health and school mental health workforces. And even if you're not part of our mental or school mental health workforce, we welcome you. Here's a map of our network. Our network includes 10 regional centers that serve all of the states and territories, a national American Indian and Alaska Native Center, a national Hispanic and Latino center, and a network coordinating office. Please visit our website and find your center so that you can stay up to date on trainings and resources offered in your region. On behalf of the network, I'd like to extend our deep thanks to the team that brought you this institute. Great staff from 7 of our centers have been working over the past few months to pull this together, and you'll be meeting them over the next 2 days. Many of them will be hosting our different sessions. A few particular shout outs, one to Leora Wolf-Person at the Pacific Southwest NIMH for her vision and leadership. She really was the driving force behind these institutes, and we are so thankful and excited to have her and her, as I said, vision and leadership, her energy, and her skill. Jennifer Barron-Prahl from Southwest NIMH I want to thank her for keeping us all organized and moving forward. And Ricky Canello from the Network Coordinating Office for his outstanding technical work to make this a reality. He is behind the scenes on all that we do over the next few days. Andrea Aliotto, also from the Network Coordinating Office, I want to extend a thanks to her as well, and she'll be picking up at the end of Dr. Shear's session with the Q&A and closing. Turning to why we're here, to date, the CDC estimates that 175,866 people in the United States have died due to COVID or COVID-related or involved causes. This, as we know, is an unprecedented number, and I'd like us to take a moment of quiet reflection to sit with what that means for us. We hope that as a community, we're able to come together in the next few days to learn, share, and grow while remaining sensitive to others and our own experiences. We've developed these two institutes, the first one now for 2 reasons. First, because many of us are navigating starting a school year, and there are so many questions about how to provide care to students and those that serve them in this moment. The second, in homage to 9/11, another grief milestone in our collective history. Please join us tomorrow for an opening that will pay tribute to 9/11. Our second institute is scheduled November 12th and 13th, also for 2 reasons. First, because it's the week before Thanksgiving, the Thanksgiving holidays, which is a time where grief and the absence of so many lost and so much difference will certainly evoke new needs and ways of being grief sensitive. The second is because we want to provide continued learning to you so that months later we can return again and deepen our practice. In addition to this institute, our team just released a series of fact sheets focused on addressing various grief-related topics, so we invite you to check those out on our website. We also have a special Responding to COVID-19 Grief, Loss, and Bereavement webpage that has more NIMH events and resources, as well as resources from around the country. Today and tomorrow, our sessions focus on grounding ourselves in the basics, so frameworks, foundations, foundational concepts, definitions, and then we're going to bring back the same speakers in November to go more in depth in applying concepts to practice. Each institute has 4 sessions that each have 3 learning tracks: grief sensitivity, evidence-based and culturally defined practices, and school mental health. So you're invited to join whichever sessions most fit your learning interests. You can go to school mental health for one session, then grief sensitivity for another. You can bounce around. All of them are open to you. We also have time for reflective discussion. So on both days of each institute, we're hosting optional breakout discussions for participants to join, listen, learn from each other's experience and expertise. These discussions are divided by track, so you can choose the one that most fits your interests. And these breakouts really are for discussion and learning from one another on a deeper level, so we encourage you to be more active participants than you can be in the larger webinar pieces. We'll also, today opening with a keynote to set the tone, and then tomorrow we'll close with an integrated activity to support our learning outcomes. So you all received a link to this document that has all of the session Zoom links and evaluation links, including the breakout discussion group. So this is your guide for the next 2 days. You can supplement that with our brochure, which has more in depth about each session and the speakers. The speaker bios. A bit of housekeeping. These are a few of the items. So we've attempted to make all of our presentations secure, but if for some reason we need to end a presentation unexpectedly, we'll follow up using registration information. If you have questions for presenters, please use the Q&A pod. And if you have a comment or a link for all attendees, you can use the chat box. The session is all the sessions for the whole institute are being recorded, and the slide decks will be posted on our website. Give us about a week and a half or so to get all of them up and ready, but they'll be posted as well. We have closed captioning. We're very excited to have closed captioning. And to view captions, you can click the arrow beside the CC box at the bottom of your screen and choose Show Subtitles. To change the size of the subtitles, click the arrow next to the CC box and choose Subtitle Settings, where you'll find the option of making the subtitles smaller or larger. Very excited to have closed captioning. We will have transcripts from the sessions also posted on the website. Again, give us a couple weeks to get that up and ready. Please follow us on social media and stay in touch. I also want to acknowledge that just as many of us are clinicians and providers and peer leaders, we're also all experiencing the turmoil and loss related to the pandemic, to racial violence, to natural disasters, all the other stresses in our lives right now. Many of us are also dealing with personal loss due to the death of loved ones and colleagues. So we want to recognize that participating in this and other sessions may activate our own feelings of grief and loss. Please care for yourself during these 2 days, including taking breaks, stretching, drinking fluids, whatever you need to do to be mindful, whatever helps you stay centered and grounded. If you feel you are in need of acute support, we have links here for helplines and hotlines. These are also listed on the Learning Institute website. I would like to warmly welcome Dr. Katherine Shear, who will set the stage with a keynote presentation, Understanding Grief and Adaptation to Loss During the COVID-19 Pandemic. Dr. Shear is the founder and director of the Center for Complicated Grief. She's an internist and psychiatrist with the heart of a social worker. She's widely recognized for her work in bereavement studies and complicated grief disorder. Dr. Shear developed a key evidence-based practice called complicated grief therapy, which has very strong evidence base across 3 National Institute of Mental Health funded randomized controlled trials. She is the Marion E. Kenworthy Professor of Psychiatry at Columbia School of Social Work and Columbia College of Physicians and Surgeons. She served as an advisor on grief and mood disorders for the DSM-5 and the World Health Organization's ICD, as well as other important national organizations. We're very thankful for Dr. Shear's work in the field, and I'm going to transition the presentation now over to Dr. Shear. Thank you.
Thanks so much, Heather, and welcome. Thank you for the opportunity actually to keynote this really amazing institute, and thank you for actually doing the institute, because it's really going to be a remarkable experience for people. And welcome also to all the participants today. I am speaking to you from Northern California, where in addition to the pandemic, those of you who don't know, we are experiencing an unusual kind of smoke from the fires that have been going on out here. So we're going to talk about grief and adaptation to loss, as Heather said, and hopefully set the tone for the remainder of this institute by providing a viewpoint that is broad enough to cover the many kinds of ways that people, I think, who are presenting may see and work with people. So the first thing I want to say is that, of course, we all know what grief is. We all have, probably almost everyone has experienced it, if not everyone, or certainly we know someone who's experienced the loss of someone close. But the interesting thing is that we don't have a uniform way of understanding it. So I want to start by that because that's partly how we're going to communicate. So take a minute to think about how you understand grief. Do you think of it as a specific emotion or more than an emotion? Is it something more than just one emotion, even a unique emotion? Do you think of grief as having stages? That's something we see a lot on the internet, and there's been a real acceptance of an idea promoted by Dr. Elizabeth Kubler-Ross a number of decades ago, talking about people who were dying. But do you think there are stages of grief? Do the 5 stages work for you? And do most people resolve grief? Is it universal or is it different for each person? And lastly, is grief complicated? Is all grief complicated, or is complicated grief a diagnosable condition? So now that you've thought it through for yourself, I'll tell you our answers to these questions. So first of all, we understand grief as a full body and mind, mental and physical response and behavioral response to a meaningful loss. So it's complex, it's multifaceted, it's time varying, and we actually think of it as the form that love takes when someone we love dies. There's absolutely no evidence for predictable stages. There are no 5 stages of grief. That's pretty clear. And it's also clear that most of us do not fully resolve grief in the sense that years, decades after someone close has died, there can be moments in time, there can be calendar days that evoke strong feelings of grief, even though for most of us, we've adapted, come to terms with that loss, and it's not so much a part of our everyday life, but it is permanent after we lose someone close. It is certainly unique to every person, and not only every person, every loss that we experience. So each of us experiences each loss in a unique way, and that's because each relationship is unique, and the way we experience grief it's related to a number of things, but it's strongly related to the relationship with the person who died. And yet, in spite of this uniqueness, important uniqueness, there are, we think, important commonalities that we're going to be talking about today. And yes, all grief is complicated. That's kind of what I've been saying about the rest of all the reasons that I've just said, and some more that I'm going to talk about in a minute. But also, complicated grief is, in fact, a diagnosable condition. It is in ICD-11, and it's about, we think, to be approved finally. It's gone through a whole process, a very long process of consideration and editing to be put forward now, hopefully, as prolonged grief disorder in the DSM-5 as well. You may have seen, well, we'll be talking a little more about that in a minute. So another thing I want to say is that it is not a form of depression. That's something some people sometimes get confused. That's probably the most likely alternative diagnosis that we see in people who actually have complicated grief. So again, it's the way we experience a meaningful loss, and it's messy. It has a lot of thoughts, different kinds of thoughts that change over time, a lot of different emotions. In fact, excuse me, we can experience virtually any kind of emotion during a period of grief. And we generally focus our behaviors on grief-related behaviors or behaviors related to the death. But grief changes, all of these things change erratically in the short run and often unpredictably, and then evolve over time as we adapt to the changes that are brought about by the loss. And the adaptation, like grief itself, is very unique to each loss and each person. It's also affected by things that we can't control. So for all these reasons, again, grief is quite complex, and so it's complicated. And here's another reason that we might think of grief as complicated, is that it naturally contains a lot of mixed feelings and confusing thoughts. So um, I'm going to not read all of this slide or not go through all of the pieces that are involved in this slide, but you'll have them later. But these are all the different ways, many of the different ways, and not all of the different ways that we can have mixed feelings and confusing thoughts when we lose someone close. So how can we understand grief? And the way that we believe is the best way to understand grief is to understand what essentially is at the root of it, which is the attachment, the closeness, the love that we feel for the person who died. And the best way to understand that is using attachment theory, which I'm guessing that most people in this audience are familiar with already. But attachment theory was promoted first by Dr. John Bowlby, an English psychiatrist in the mid-19th century, mid-20th century actually, the 1960s, as a theory that the motivation to form close relationships is actually part of our biology. And these relationships are with people who we want to be with and not be separated from, all things being equal. And they function as a safe haven and a secure base, meaning they're the people we turn to when things are not working well for us in our life, when we're stressed or threatened or when we feel bad in almost any way. And they will provide us with comfort and support, and often with even instrumental help. Knowing that they're there is hugely important in our life. But that's not all they do. They also are sort of they help us feel confident. They're our cheerleaders and coaches. They provide us with that secure base when we go out into the world and we learn new things and perform in the world and do things that we're interested in. So that's the secure base function. And that's not even all, because also our close relationships actually serve as regulators of our bodies and mind in all the ways that are listed on this slide, which is actually not the most up-to-date version of this, and it also doesn't include the specific references to the studies. There's at least one publication, and often there are dozens of publications about each of the topics on this slide. So you can see the people we love have a profound influence on our lives. So it's not surprising that their loss impacts us greatly. And that still isn't all, because the attachment system is linked to other biobehavioral motivational systems. Importantly, I think, for grief, including the caregiving system and the exploratory system. And what's important, so caregiving is again, the natural inborn biological motivation to provide a safe haven and secure base to the people that we love. And for adults, and maybe even a little bit for children, it's even more important to our well-being than being cared for well ourselves. So when someone we love dies, again, we're not going to feel effective as a caregiver. That's going to undermine, it's one of the ways that our sense of effectiveness is undermined by the death of a loved one. And similarly, the exploratory system is very linked to attachment security, to feeling that that person that is important to us is there and functioning in those safe haven and secure based ways. And so when that's in place, then we're free to go out and explore the world and learn new things and just interact with other people. When there's a threat to the attachment system that deactivates exploration, meaning that we're no longer interested in doing any of those things. And also it affects our sense of competence in doing so. So what happens, I've been talking about this when a loved one dies, well, it affects the attachment system, the caregiving system, and the system of the exploratory system in a way that maps directly on to what we think of as common manifestations of grief, which are listed on the right side of the slide. So really, the loss of a close relationship pretty much explains the core symptoms of grief. And that's why we say that grief is the form love takes when someone we love dies. We think that is quite literally the case. So what we're saying is that people almost always are going to react very strongly to losing someone close. That's something I probably don't even need to say. And also, we still almost always adapt to this unwanted reality. And this is a quote on here from C.S. Lewis, which talks about this kind of, the adaptation process, again, is rooted, it's rooted in our biology. It has, of course, a strong mental side, but it isn't always explicit. It's not necessarily something we have to like walk our way through. We just have to not get in the way. So what does it entail? It means what, from, again, we're talking from a high level, big picture perspective. What adapting to a loss means is going to be very, very specific to each person and each loss, again. But taking that big picture perspective, we're going to say that we need to learn to accept the reality and find ways to restore our well-being. That's at the heart of what we mean by adapting to loss. And this slide also talks about some of the specifics in loss as opposed to adapting to anything else, because really when we adapt to anything, we have to accept the reality of whatever it is we're adapting to and restore our well-being. But in the case of loss, this slide kind of talks about how what some of those things that we have to do are. And importantly, as I said a minute ago, adapting is really facilitated naturally by what we all have, which is a kind of psychological immune system that protects our sense of well-being in the face of negative experiences, it threats to our sense of well-being, really, in somewhat analogous way that the physical immune system protects our bodily, physical well-being in the face of threats to physical well-being. So again, we're saying that grief is going to emerge naturally in an acute form that, again, from a big picture, has the strong emotions, the insistent thoughts, grief-related behaviors, physical symptoms, and also often a spiritual component and definitely a social component as well. And it's transformed as we adapt to the loss, finding a place in our life as what we call integrated grief, in which the physiologic changes that I alluded to a little earlier, due to those physiologic regulatory functions that a close relationship provides, physiology is re-regulated, and the thoughts and memories of the person who died find a place in our life. They're not gone, but the emotions are better regulated and more bittersweet, and the thoughts that we have about the person tend to recede into the background, but they're still, of course, accessible. We don't forget the person. We don't not know, how we think about them. They kind of grow and change with us, but they're certainly still accessible, and we become more connected to our everyday life. And just one thing, a comment about this is that integrated grief is usually in the background, but it's not always so soft or quiet. And I mentioned this earlier, at times, at calendar days, like Heather mentioned, the upcoming winter holidays starting around mid-November and going really all the way through to early January, very often people who are doing fine are a little bit activated or even very activated emotionally and start to think a lot about the person who died that they wish was here to help join them in celebrations and family gatherings and such. That's just one example of times when integrated grief isn't so quiet. It's still integrated, but it isn't so quiet. And another thing about grief is that there are some elements that are, we think of them as natural stopping points in the process of adapting. They, again, this is all very natural, and it's a little bit like the stages, but these things don't operate so much as stages as just kind of stopping places that we might revisit and often do revisit as we move along that adaptation process. But if we don't engage with them, if we don't, in a sense, learn from them and resolve these to a great extent, they can derail that process of adaptation. So we'll be talking a lot more, a little bit more about them in a minute and a lot more about them in November. The result of this is that condition that I alluded to, prolonged grief disorder, which is essentially a persistent and pervasive yearning and longing for the person who died, or preoccupation with thoughts and memories of them. Those usually go together, accompanied by intense emotional pain. This is the ICD-11 prolonged grief disorder guideline. And the DSM that is being proposed for final approval by the American Psychiatric Association board is very similar, but it's a little bit better specified. These criteria were published by the APA for public comment back in April and May last spring, and some of you may have seen that and made your comments, which are, of course, very welcome. We have been very involved in this process at the Center for Complicated Grief, and we're actually proud of that. That's something that I know is controversial, but that's maybe something we can talk about if there are questions. So there are risk factors that increase the risk that these derailers will kind of get that foothold and therefore cause essentially prolonged grief disorder. Some of them are person related, those are listed here. Some are related to the relationship with the person who died, which is when the more it is an identity defining relationship, the more deep dependency the bereaved person has had on the person who died. And also the more that this is actually a strong, secure, well-functioning relationship in the context of more general attachment insecurity. Those are all risk factors of the relationship with the person who died. And then the circumstances are also very much related to risk factors for derailers and PGD. And in particular, any kind of sudden unexpected death is one that will approximately double the risk for the onset of PGD. And COVID-19 is certainly one of those things. As Heather mentioned, we're seeing, of course, this worldwide pandemic, and associated with this pandemic, a death toll of way more than we've seen in many wars or any kind of natural disaster, or any of that, and it's ongoing, of course. And I looked it up this morning for another purpose, and I think it's up to over 190,000 people. And there was a recent article by demographers published in June, which is it's really the first actual sort of data-based assessment of how many bereaved people in the United States we would expect to see with each and every loss. It isn't really specific to COVID-19, but this paper focuses on COVID-19. And what they're saying is that we expect the death toll to be nearly 10 times the number of deaths. So that is a huge number of bereaved people. And if we estimate that on average, after a natural death, there's about 10% of these people will develop prolonged grief disorder. That's an enormous number of people as well. And of course, one of the things that's pointed out by this paper is that what we already know, that the rates of infection, the proportion of deaths that come from every infection, and also the burden of bereavement is significantly, statistically and clinically significantly elevated in the Black population. So that's another thing that we need to be paying huge amounts of attention to. So these COVID-related deaths, and really deaths during the pandemic, even if they're not COVID-related, contain many of these risk factors, especially related to how the death happened, and so the circumstances of the death and the context and some of the consequences of the death, again listed in this slide enormously important, and important to be alert to when you're doing grief therapy, because what we're going to do to meet that challenge, and I'm just going to introduce a few minutes of this to talk about this issue, because we'll be talking about a lot more in November, but we're going to try to facilitate adaptation to loss. We're not going to work to lower grief. That isn't what we're going to try to do. Even though people, you see, people who come to you, they always want to either, they want to feel less pain, and they want their grief, they want to make sure they're grieving correctly. But we take the position that neither of those is important. We do want to help people manage emotional pain, but we don't want to help them push it away in any way. We think that you can learn from emotional pain important things, and also that it's kind of inevitable in a bereavement situation. We do want to find and address derailers. So in our efficacious treatment for PGD, we use 7 core procedures that are listed on this slide, and we'll be talking about a lot more in November. And as Heather mentioned, we've done 3 NIMH-funded studies, including 641 participants. To my knowledge, this is the largest data set for any grief therapy that in this kind of RCT study. And the results, and we always compared our treatments to a really good treatment for depression, because we knew that a lot of people were being referred for treatment for depression. And if the treatment for depression was just as good as the treatment for grief, that's in a way that then we were home free in a sense. We wouldn't have to do the work of figuring out exactly how to treat bereavement. But that wasn't the case. As you see here, these are actually very, very powerful results for this kind of study, even though, of course, not everyone responds to the grief therapy that we provided. That's important too. So we extracted from those 7 themes that I showed you, or the 7 procedures, we extracted 7 themes, and we developed a sort of acronym that you might like to use that's listed on this slide. The acronym of HEALING talks about the milestones that you can look for as you're working with a bereaved client. And I think it can be helpful that we want people to honor their grief and let it find a place in their life. We want them to embrace both painful and pleasant emotions. We want them to accept the reality of the loss, and in a way that allows them to connect with their own intrinsic interests and values. That's what's going to be very central to restoring well-being, as is living with reminders of the loss and allowing them to be bittersweet, and integrating memories of the person who died, which can be used really often to help people learn and grow. People want to be able to, it's important to be able to narrate stories of the death, at least a story of the death, for oneself, and also to share with others for a variety of reasons that, again, we'll be talking about in the future. And last but certainly not least, and not the last thing that we do with people either, but is to help people let other people into their life. Often there are supportive people around a bereaved person, and it's hard to be open when you're bereaved. So we work with people to help them do that. This is the word derailers can be used also as an acronym to kind of think about the stopping places that can derail that process if they don't get attended to. And I won't walk through each of these, but I do want to mention survivor guilt, because we haven't talked about that yet. And that's absolutely, as far as I can tell, universal after losing someone close. That's the feeling that it isn't somehow right. It's sort of uncomfortable or not right to experience positive things in your life when someone you love has died. So that has to be dealt with. So in our work, we use these 4 foundational premises that, first of all, grief is a form of love, as I've been saying, emerges naturally, finds a place in our life, that adapting to loss will progress naturally if it's not impeded, that everyone grieves and adapts in their own way. We've been talking about that. And that we don't grieve well alone. I've sort of alluded to that, but that's another really important point. It's very, very difficult to grieve well fully alone. That doesn't mean that we don't need private time. We absolutely do when we're grieving, but having at least one confidant with whom we can share just the pain and share our thoughts and share the sort of glitchy things, those mixed feelings and confusing thoughts and the stopping places where we can talk to someone. It's really, really important in the process of adapting to loss. So our work involves active listening, which I think every single grief therapy, that's something that's really shared, as is, I believe, the use of validation support and guidance is, so we do use guidance. We use guidance in the ways that I was talking about. We really look for ways to encourage people to move through those healing milestones and to address the derailers. And so again, something we'll be talking about a lot more in November, but certainly validation support and active listening are going to be absolute universals in very important universals in grief therapy. So I like to think of grief therapy as having that core of active listening, using the model that I've talked to you about, which is a big picture, broad model, to try to warm things up for a grieving person, turn on a light, and open a door to the outside world. So, in summary, grief emerges naturally after an important loss. COVID-19 deaths and deaths during the pandemic in general have many elements that are likely to be especially challenging, and yet most people will, we know that the majority of people will adapt. Maybe they'll adapt more quickly or more slowly. People do this in their own way, and certainly not 100% fully, and that's not what we're talking about when we are talking about someone having prolonged grief. It doesn't mean that either you have grief, some grief present, or you have no grief. That's not what we're talking about. We're just talking about a process that's clearly underway by 6 months or a year. So one of the ways that that can be promoted is that to recognize that it's important not to be judgmental about oneself, what one is experiencing. It's really that sort of layers on more pain and more pressure than a bereaved person is already going to be feeling to just adapt to the loss. So we want to help people not be judgmental and to seek and savor positive feelings when they're dealing with a loss, because positive feelings, we know, are healthy ones, both physically healthy actually, and also mentally help us to problem solve and to be open to creative solutions, which is something that is very, very helpful in adapting to loss. Supportive companions are very important, as I was mentioning, and can be hard to manage. It can be hard to manage those relationships, and very often they end up being disappointing, and so that's one of the reasons. And lastly, what I consider a mantra in my work is basically my version, I guess, of the serenity prayer, which is that whenever we're trying to solve a problem or adapt to something unwanted, we need to accept what we can't change, find what we can change, and of course, figure out which is which is often one of the hardest things to do. So I'm going to end at this point, and I hope we have some time for questions, but thank you very, very much for your attention. So maybe I ended even early. I don't know. Let's see. Did I? I did okay.
Thank you very, very much, Dr. Shear. We really appreciate you sharing your expertise with us this morning. We do have some time for questions, and we have a number of excellent questions in the Q&A pod. So I will lead us through the Q&A portion this morning.
Great.
Okay, so one question that we have is, are grief and complicated grief interchangeable? If so, is complicated grief used simply for diagnostic purposes?
So actually, probably they are used interchangeably, but that might be confusing to people. So I would say, since they're probably used interchangeably, I would advocate for the use of the term grief, but just to understand that it is always complicated. And what's great in a way is that the term used by the ICD-11 and DSM-5 committees is prolonged grief disorder. So what we have been calling complicated grief, maybe not accurately, is now being called prolonged grief disorder. And so we don't have to confuse those two.
Thank you. The criteria for prolonged grief disorder have to be present for at least 12 months. Is that correct? Is it possible for these symptoms to be present and then not throughout the rest of the year?
It's not, it is not considered prolonged grief disorder. That's a very important point. So it is not considered prolonged grief disorder if these symptoms are present for a period of time and not the rest of the year. That's the situation I was trying to point out with one slide, but that is very, very, very common. And it's important to know that because there isn't necessarily a problem with adapting to grief. People need to know that it's very natural to see that upsurge in grief at certain calendar days during and especially periods of time around, especially the winter holidays, I would say is almost universally like that. So and it's in terms of what is the time frame, ICD-11 says 6 months and DSM will say 12 months. So we don't, there's lots of issues around how to identify that timing. But I would say, to me, it's certainly the case that after 12 months, if someone is still having persistent, intense yearning, longing, and preoccupation with the person who died, and a lot of emotional pain associated with that, as well as, I didn't mention this, but to a degree that impairs their functioning, that is, then I would say the person has prolonged grief disorder. And that is important because although what I've been talking about today, certainly you don't have to wait for someone to develop a prolonged grief disorder to use this kind of intervention that we'll talk about more again in November, but you would certainly want to do that, or something that has been tested if we are beyond a year and the person is really being impaired and experiencing a lot of distress and impairment from their grief, specifically in an ongoing way, persistent way. Yeah.
Okay, thank you very much. One more question we have time for, I believe, is whether we're seeing any connection between moral injury and complicated grief in frontline healthcare workers.
Yeah, I mean, I think the topic of moral injury is incredibly important. I personally learned about this because I'm a member of the disaster committee of the American Psychiatric Association. And in that context, I started reading a lot about the healthcare workers. I haven't seen myself so many of the healthcare workers grieving. I think there's a lot of trauma, there's a lot of stress. I have been a little bit involved in that. But the point is that moral injury, I think, is rampant in this situation, in the COVID situation. However, we honestly we don't really know. I guess if if someone is grieving a COVID, if a healthcare worker is grieving a COVID loss, either in their own family or loss of a patient, and they also are struggling with moral injury, I would be very, very surprised if that didn't increase the rate, yes, of prolonged grief disorder, that would be a real risk factor. Thank you for that question, because I really hadn't focused on that. And I guess everyone knows what moral injury is. I guess, do we have time to quickly say that?
Please,
Yeah.
please.
So a moral injury is a feeling that you are unable to act consistently with your own values, and or unable to stop someone else from acting in a way that is antithetical to your own values. And that creates a specific kind of stress that we call moral injury. And it occurs typically in situations, well, it was first defined in the military, where military troops were faced with situations where, for example, they were having to kill civilians, and that actually goes against all of their values, and it was very distressing, and they had no choice in a way. And in the healthcare realm, some of the horrible procedures that have occurred around decisions around early, in April, May, March, April, May, even around ventilators and COVID is an example of this. The Italians first wrote about this in what they were facing with ventilators and not having sufficient numbers of ventilators. And how do you know? You have to put someone on it who needs it, and you have to not put someone on it who needs it. And that is a really hard decision for a healthcare provider, and creates a sense of moral injury in many of them.
Thank you,
So,
Dr. Shear. We have many, many more excellent questions, but unfortunately we don't have time to answer all of them right now. Dr. Shear has generously offered to answer each of your questions after today's presentation via email, and her responses will be distributed to today's registrants after today's presentation. Just want to say thank you so much again for your excellent expertise and presentation this morning, Dr. Shear.
thank you, Heather, and thanks to everyone in the audience who's here and who's taking their time to participate in the Institute for however many days it is. It's really, and for all of you for putting it together. It's an honor to be here, and I wish you the very, very best.
Thank you. And in closing, we would ask that everybody who is in attendance this morning to please take a moment to complete a brief survey about today's session. Your feedback is very, very important to us. Once you click on the link, you will be redirected to the survey once you close the Zoom platform. And thank you for everyone who joined us this morning. It has been our pleasure to bring this session to all of you. Today's presentation slides and recording will be available on our website within the next week or so. And coming up next, we have about a 10-minute break, followed by session 1 at 10 a.m. Pacific time and 1 p.m. Eastern. So please join us for one of the 3 presentations taking place at that time. So you have the choice of joining either No Time Clock on Grief, Reimaging Healing and Learning Spaces, Understanding Loss and Grief in Uncertain Times, or Reviewing the Basics of Grief Counseling. After session 1, we will have lunch and our first round of optional breakout discussion groups. Thank you, everyone.